Hello, ladies and gentlemen. Our public education of medical oncology program series continue and new one. The indolent lymphomas. The indolent non-Hodgkin lymphomas represent approximately 1/3 of all malignant lymphomas. Most are of B-cell origin. Follicular lymphoma is the most common indolent lymphoma. Other indolent B-cell lymphomas include small lymphocytic lymphoma, chronic lymphocytic leukemia. The marginal zone B-cell lymphomas, MZZL, extranodal, nodal and splenic, and lymphoplasmacytic lymphoma, most cases of which are more specifically classified as Waldenström macroglobulinemia. Mantle cell lymphoma can morphologically resemble indolent B-cell lymphomas, but it is clinically more aggressive and therefore is not covered in this chapter. Indolent T-cell non-Hodgkin lymphomas, NHL, such as mycosis fungoides, are also not covered in this chapter. This program source book is the M.D. Anderson Manual of Medical Oncology. Clinical features, but first the follicular lymphomas. Follicular lymphomas represents 22% of all non-Hodgkin lymphomas and 80% of indolent B-cell lymphomas. Follicular lymphoma occurs almost exclusively in adults with an equal frequency in men and women. Follicular lymphoma patients typically have a relatively long survival with a median of 8 to 10 years in the pre-rituximab era. Outcomes are improving in recent years. Clinical features. Patients with follicular lymphoma, most often present with asymptomatic lymphoadenopathy, constitutional symptoms such as fever, drenching night sweats, and significant weight loss occur in approximately 15% of patients. Patients may have symptoms related to lymph node enlargement, especially when there are bulky masses in the retroperitoneum. Other symptoms can include fatigue and occasionally end organ. Consequences such as obstructive uropathy or bone marrow compromise. Central nervous system disease is rare. Urgent situations such as the superior vena cava syndrome or spinal cord compression are rare. is part related to usual slow pace of growth, lymphadenopathy, follicular lymphoma, spontaneous regression of lymphadenopathy can occur in follicular lymphoma. Such regressions, however, are usually partial and are typically short-lived. The potential of follicular lymphoma to wax and wane provides one of several clues that suggest that the host immune system can play an important role in the disease course in follicular lymphoma. Consequently, follicular lymphoma has been a prime focus for immunotherapy approaches. Approximately 80 to 90% of follicular lymphoma patients present with advanced stage disease, stage 3 or 4. With generalized lymphadenopathy, the bone marrow is involved in approximately 50% of patients. Follicular lymphoma patients can ultimately develop histological transformation to diffuse large B-cell lymphoma at the rate of about 1-3% per year. Clinical features suspicious for transformation include rapidly progressive lymphadenopathy, systemic symptoms, localized pain, and rise in serum lactate dehydrogenase level. Lactate dehydrogenase and alkaline phosphatase, most of the so many neoplastic condition generally give us as parameter clues. Why? Because cancer disease is a chronic disease, and step by step anemia and destruction of red blood cell and lactate dehydrogenase in the cellular membrane of red blood cells and pouring the serum level and increasing. So many details about physicians, doctors, diagnostic workup and staging, prognostic factors, post-treatment monitoring, treatment of limited stage, management of advanced stage follicular lymphoma, and different chemotherapy, consolidation therapy, vaccines, biological therapy, maintenance biological therapy, and so on. Salvage therapy. Small lymphocytic lymphoma, chronic lymphocytic leukemia. Small lymphocytic lymphoma represent approximately 7% of all non-Hodgkin lymphomas. The World Health Organization classification restricts small lymphocytic lymphoma to tumors involving lymph nodes with the same B-cell immunophenotype as chronic lymphocytic leukemia without leukemic involvement and considers small lymphocytic lymphoma to be the nodal or tissue counterpart of chronic lymphocytic leukemia. Clinical features and management. Patients with small lymphocytic lymphoma often present with asymptomatic lymphadenopathy. B symptoms are uncommon and are observed in less than 10% of patients. Splenomegaly is common. Bone marrow is often involved in approximately 70% of patients, although the traditional staging system for small lymphocytic lymphoma and chronic lymphocytic leukemia are different. These systems share common features, and the prognosis of patients with small lymphocytic lymphoma is similar to those with chronic lymphocytic leukemia. Management strategies for patients with FL and chronic lymphocytic leukemia are often applicable to patients with small lymphocytic lymphoma, but there are some caveats. For instance, as CD20 is usually dimly expressed by small lymphocytic lymphoma ratio divided chronic lymphocytic leukemia. Anti-CD20 antibody therapy for small lymphocytic lymphoma may be better modeled on the result in the chronic lymphocytic leukemia literature rather than the result of patients with FL. Conversely, the response to anti-CD52 antibody therapy, alemtuzumab, seems to depend greatly on tissue penetration, and response is often inadequate at site of bulky disease. The small lymphocytic lymphoma divide chronic lymphocytic lymphoma patients. Nodal marginal zone lymphoma, of course, very detailed, but generally this study passing superficial, not deep condition. Nodal marginal zone lymphoma, clinical features and management. Patients with nodal marginal zone lymphoma typically present with peripheral and or para-aortic lymphadenopathy and bone marrow involvement. The 5-year overall and failure-free survivals are lower for patients with nodal marginal zone lymphoma compared with patients with MALT lymphoma, 56% versus 81% and 28% versus 65% respectively. The treatment and outcome of patients with nodal marginal zone lymphoma is similar to that the patient with advanced follicular lymphoma FL. Splenic B-cell marginal zone lymphoma. Splenic B-cell marginal zone lymphoma. Clinical features and management. Patients with splenic marginal zone lymphoma, usually SMZL, usually present with splenomegaly. They commonly have modest abdominal lymphadenopathy and bone marrow involvement. Monoclonal gammopathy can be seen in 10 to 20% of patients. Peripheral lymphadenopathy and B-type symptoms are uncommon. The clinical course is indolent, with 5-year overall survival ranging from 65 to 78%. Approximately 1/3 of patients with splenic marginal zone lymphoma will never require therapy. Splenectomy is indicated in patients with symptomatic splenomegaly or cytopenia secondary to hypersplenism. If splenectomy is contraindicated, splenic irradiation may be an alternative. Alkylating agents have been used, but responses are usually partial and not durable. Patients treated with fludarabine demonstrate a higher response rate and longer lasting remission than those treated with alkylating agents. Rituximab has significant activity is splenic marginal zone lymphoma. Lymphoma, lymphoplastic lymphoma and Waldenström macroglobulinemia. Lymphoplasmacytic lymphoma and Waldenström macroglobulinemia. In the current version of the World Health Organization WHO classification, LPL is defined as a neoplasm composed of small lymphocytes, plasmacytoid lymphocytes, and plasma cells that most often involves the bone marrow, but can also involve lymph nodes and spleen. Lymphoplasmacytic lymphoma, LPL shortly, is often associated with serum immunoglobulin M paraprotein, but this feature is not required for diagnosis of LPL. Patients with LPL also can have a serum paraprotein composed of immunoglobulin A or immunoglobulin G, and the relationship of these cases of WM is not clear. In contrast, patients with Waldenström macroglobulinemia have LPL involving the bone marrow associated with the serum immunoglobulin M paraprotein of any level. Using this definition, all patients with WM have LPL, but not all patients with LPL have WM. Patients with LPL not meeting the criteria for WM are rare and poorly characterized. Furthermore, is serum immunoglobulin M preparation paraprotein can be observed in patients with other types of indolent B-cell lymphoma, and there is morphologic and immunophenotypic overlap with MZ marginal zone lymphoma, MZL. For these reasons, our focus here on WM clinical features. Clinical features. Some patients with WM can be asymptomatic, but many have symptoms of anemia, which is common presenting feature. Only about 15% of patients have splenomegaly, hepatomegaly, and or lymphadenopathy. The hyperviscosity syndrome characterized by mucosal hemorrhage, visual disturbances, neurologic changes, and cardiac failure is dramatic and classic, but occurs in only a minority of WM patients. Other even less common manifestations include cryoglobulinemia, cold agglutinin hemolysis, autoimmune thrombocytopenia, amyloidosis, and light chain nephropathy. Histologic, immunophenotype, and molecular features, very deep detailed management. In conclusion, the date most advanced stage indolent B-cell lymphomas remain incurable. Novel approaches to therapy are continuing to be explored, including monoclonal antibodies, radioimmunoconjugates, and immunotoxins. These and other biological approaches to therapy will likely play an increasingly important role in the management of patients with indolent lymphoma. Allogenic transplantation in indolent B-cell lymphomas continues to be an area of heightened interest, especially with the development of better tolerated mini-allogenic transplant strategies. The importance of the graft versus lymphoma effect reflects our growing knowledge that the host immune response is a potential powerful tool that have not yet fully exploited. Vaccine strategies are also of considerable interest as emerging biological therapies become integrated with the best of conventional therapies. It is hoped that curative therapy will be found for more patients with indolent B-cell lymphomas. That's all this program, and we are continuing one more subject: aggressive and highly aggressive B-cell lymphomas. Aggressive and highly aggressive B-cell lymphomas. Although not a part of current classification system for non-Hodgkin lymphomas, NHL, it is clinically useful to divide NHL into indolent, aggressive, and highly aggressive tumor. Patients with indolent NHL typically have a survival of several years, even if untreated, but paradoxically are usually incurable. Patients with aggressive non-Hodgkin lymphoma have a survival time measured in months if untreated, whereas patients with highly aggressive non-Hodgkin lymphoma have a survival of only weeks to a few months if untreated. However, both aggressive and high aggressive non-Hodgkin lymphoma NHLs are chemosensitive and are frequently curable. In this chapter, we focus on the clinical characteristic, pathology, and treatment of aggressive and highly aggressive non-Hodgkin lymphoma. Epidemiology, the incidence of non-Hodgkin lymphoma has increased significantly over the last 5 decades. As reported by United States and international registries, during the years 1993 to 1995, the age-adjusted incidence increased by 3% per year according to data from the Surveillance, Epidemiology and Results Program of National Cancer Institute. There was also a concomitant increase in mortality during the same period. Some of these increased incidence can be attributed to the advent of the acute immunodeficiency syndrome, but that does not explain the increase of non-Hodgkin lymphoma prior to 1980s. There has also been a marked increase of non-Hodgkin lymphoma in the elderly population. However, it is indolent non-Hodgkin lymphomas that have increased most substantially in this group. These are discussed in another chapter. An estimated 65,980 new cases of non-Hodgkin lymphoma will be diagnosed in the United States in 2009, and 20,790 non-Hodgkin lymphoma-related deaths will occur. These are estimated to be the 99th largest cause of death. 9th largest cause of death among United States men, and the sixth in women. In 2009, 3 and 4% of cancer-related deaths, respectively. There is a higher incidence among Caucasian, the African Americans in the United States, especially among the elderly, but recent increases in the incidence among younger cohorts of African Americans have been noted. Lower incidence is also seen among other American racial subgroups, although almost all histological type of non-Hodgkin lymphoma have increased in the incidence over the last 20 years. The relative frequency of aggressive and highly aggressive non-Hodgkin lymphoma has remained relatively stable. Etiology. The causes of risk factor for non-Hodgkin lymphoma can generally be divided into 4 groups. Immune suppression, both acute and primary. Infectious agents, toxic exposure, and familial. The strongest association is with immune suppression, both primary and acute. Examples of primary immunodeficiency include inherited immune disorders such as Wiskott-Aldrich syndrome, serve combined immune deficiency, common variable immune deficiency, and ataxia telangiectasia. These diseases and other inherited disorders are associated with an increased lifetime risk of developing non-Hodgkin lymphoma, with aggressive B-cell non-Hodgkin lymphoma being the most common. Patients who are immunosuppressed for therapeutic reasons, for example after organ or bone marrow transplantation, are also the increased risk of non-Hodgkin lymphoma, especially if treated with cyclosporine, azathioprine, prednisone, or monoclonal antibodies for the removal of the T cell. A loss association can be drawn between the level of immune suppression and the level of lymphoma risk. It has been noted that transplant patients treated with the highest doses of immunosuppressive agents, such as heart transplant recipients, are at greater risk of developing lymphomas. These lesions are also more likely to be aggressive extranodal forms. Individuals treated with pharmacologic immune suppression for autoimmune disorders such as systemic lupus erythematosus, Sjögren syndrome, Felty syndrome, or rheumatoid arthritis are also at increased risk for non-Hodgkin lymphoma over their lifetimes. A subset of these non-Hodgkin lymphomas is histologically aggressive and associated with Epstein-Barr virus. These lesions may regress following withdrawal of immunosuppressive agents. Infectious agents associated with development of the aggressive non-Hodgkin lymphoma include human immunodeficiency virus, HIV, Epstein-Barr virus, EBV, human herpes virus AIDS, and human T-cell leukemia virus, HTLV. The greatest factor involved in the worldwide increase in non-Hodgkin lymphoma, at least prior to the advent of highly effective antiretroviral therapy, is HIV infection. The risk of non-Hodgkin lymphoma is increased by as much as 300% in HIV-infected patients, rising in proportion to the duration of the HIV infection, although the risk of non-Hodgkin lymphoma in HIV-infected patient appears to be decreased by antiretroviral therapy. Their relative risk of non-Hodgkin lymphoma continues to be much higher than that for those not infected with HIV. Aggressive non-Hodgkin lymphoma can occur in HIV-infected patients at any stage of infection, but the risk goes up dramatically as CD4 counts drop to less than 100 times 10 upper 3 millimeter cube. Epstein-Barr virus also plays a role in lymphomagenesis. In cases of non-Hodgkin lymphoma associated with Epstein-Barr virus, infection appears to be related to chronic antigenic stimulation by the virus. Epstein-Barr virus is virtually always present in some types of non-Hodgkin lymphoma, such as endemic African Burkitt lymphoma and extranodal T-divide and key lymphoma of nasal type. Other non-Hodgkin lymphoma types are infected by Epstein-Barr virus in subset of cases. Many HIV-related lymphomas are also infected by Epstein-Barr virus and primary central nervous system lymphoma, an uncommon late-stage complication of HIV infection, is infected by Epstein-Barr virus is essentially 100% of cases. Herpes virus 8 is associated with primary effusion lymphoma, which tends to occur in HIV-infected patients. HTLV1 is associated with adult T-cell lymphomas, leukemia. Environmental and occupational exposure to the toxins have been associated with the increased risk of non-Hodgkin lymphoma. Herbicides, especially phenoxyacetic acid derivative, are associated with non-Hodgkin lymphoma, especially in the farming belt of United States. Occupation reported to be increased risk for non-Hodgkin lymphoma include farming, metalworking, forestry, woodworking, and dry cleaning. Chemicals. One of the common exposure in these industries is the use of organic solvents. With long-term follow-up, aircraft maintenance workers who use multiple solvents were also found to be at increased risk for non-Hodgkin lymphoma. Familial history of non-Hodgkin lymphoma is also risk factor. Individuals who have relatives with non-Hodgkin lymphoma also have a slightly higher risk of developing non-Hodgkin lymphoma. In one study, the risk was higher for siblings, and for male relatives, the genetic causes that explain familial lymphoma are poorly understood. Clinical presentation. The clinical presentation of aggressive non-Hodgkin lymphoma varies substantially based on histologic type and anatomic site of disease. Approximately 50% of patients present with B symptoms, fever greater than 38 centigrade, night sweats, or weight loss greater than 10% of body weight in the preceding 6 months. The likelihood of B symptoms increases with the aggressiveness of non-Hodgkin lymphoma. Fatigue and malaise are less frequent than B symptoms, and pruritus is unusual. More than 60% of patients present with painless peripheral lymphadenopathy. Often the patient with localized nodes are first treated with antibiotics for a presumed diagnosis of infection, which proves to be an incorrect diagnosis when the nodes fail to regress. Both external and internal lymph nodes are commonly involved by non-Hodgkin lymphoma. Symptoms vary with the anatomic side of lymphadenopathy. Those patients presenting with mediastinal adenopathy frequently experience cough, chest pain, and sometimes superior vena cava syndrome, although this is much less frequent than with solid tumors. Those patients presenting with large nodal masses in the abdomen or retroperitoneum frequently experience pain, abdominal fullness, or early satiety. Retroperitoneal tumors can cause back pain and discomfort. More frequently, peripheral lymph nodes are discovered before internal lymph node cause symptoms. Peripheral lymph nodes are not usually painful until they have become massively enlarged. Extranodal disease is common in patients with aggressive and highly aggressive non-Hodgkin lymphoma. Larger tumors, especially in the gastrointestinal tract, can present with obstruction, blood loss with subsequent anemia or diarrhea. Classically, the most common extranodal side of lymphoma is the stomach, followed by the intestines, tonsils, and skin, although the published frequency of involvement of these sites varies across reports. Other extranodal sites include liver, lung, testis, bones, central nervous system, and spleen. Pulmonary lesions can present in the lymphomatic, lymphangitic, nodular, or alveolar pattern, sometimes with cavitary lesion reminiscent of lung cancer. Primary bone lesions are typically quite painful. Aggressive extranodal disease may invade almost any tissue or organ system. Clinicopathologic characteristics, so many details. Some information other lymphoma, mantle cell lymphoma. The term mantle cell lymphoma is the currently accepted name in the World Health Organization classification for a neoplasm, previously known as malignant lymphoma, intermediate lymphocytic type, lymphocytic lymphoma, or intermediate differentiation, centrocytic lymphoma, and mantle cell zone lymphoma. Mantle cell lymphoma represent approximately 60% of all non-Hodgkin lymphomas. Clinically, patients with MCL, marginal cell lymphoma, are usually elderly men with a median age in the 7th decade. The male-female ratio is approximately 3:1. Most patients present with clinical stage 3 or 4 disease and generalized lymphadenopathy. Systemic symptoms occur approximately 40% of patients. Bone marrow is involved approximately 6% of patients. Burkitt lymphoma. Clinically, Burkitt lymphoma may be divided into 3 groups: endemic, African, sporadic, non-endemic, and AIDS associated. A leukemic form of Burkitt lymphoma also occurred, designated by the French-American British group as acute lymphoblastic leukemia. L3 now recognized in the World Health Organization classification as leukemic phase. Endemic Burkitt lymphoma was first described in Equatorial Africa, Uganda. Evidence of Epstein-Barr virus infection is present in 95% of patients. The median age of patients with endemic Burkitt lymphoma is 7 years, with the boy-girl ratio 3:1. The jaw is the best known site of disease, involving either the maxilla, upper jaw, maxilla, or mandible, down jaw. In 65% patients, but large abdominal masses involving retroperitoneal structures, the gastrointestinal tract, on the gonads are genitourinary tract. Gonads are also commonly present. Sporadic Burkitt lymphomas occur in industrialized nations and represent less than 1% of all non-Hodgkin lymphomas. Epstein-Barr virus infection is pre-affected are usually in the 2nd or 3rd decades of life, with the male-female ratio of 3:1. The jaw is infrequently involved, and most patients present with large abdominal masses frequently involving the ileocecal region of the bowel. Other sites commonly involved include abdominal and peripheral lymph nodes, pleura, and pharynx. In patients with either endemic or sporadic Burkitt lymphoma, bone marrow and central nervous system involvement are uncommon at presentation in approximately 10 to 20% of cases, but they are frequent sites of subsequent dissemination. Burkitt lymphoma can also occur in the clinical setting of HIV infection. These neoplasms are associated with Epstein-Barr virus infection in 30 to 40% of cases and commonly involve lymph nodes or extranodal sites. And continue. Staging and initial evaluation, prognostic factors, pre-treatment. These are detailed and just only for physicians, doctors, and different medical degree owners. Post-treatment approach to therapy: early stage aggressive non-Hodgkin lymphoma, advanced stage aggressive non-Hodgkin lymphoma, highly aggressive non-Hodgkin lymphoma, treatment of recurrent mantle cell lymphoma, surveillance, relapse or recurrence, and last command, new directions. Over the last 20 years, remarkable advances have been made in the diagnosis, characterization, and treatment of patients with aggressive non-Hodgkin lymphoma. Most of advances in therapy have been in the realm of chemotherapy and radiotherapy, but new technologies such as monoclonal antibodies have made a significant impact. Although the advances in the area of traditional chemotherapy remain to be discovered, it is likely that new therapeutic modalities will become more important research areas. Likely to be important in the near future are bioimmunotherapy with vaccines, newer monoclonal antibodies, and novel agents that target specific genetic lesions. Some of these approaches, lymphoma vaccines and targeted molecular technologies, are currently undergoing clinical trials. Although success to date is not confirmed and additional studies are required, the initial results are promising. Clinical research continuing. By different researchers. That's all this program, and thank you so much. Thank you very much. You are patient. I hope this program useful. Just only public health education. Public health education and superficial, not detailed or therapeutic modalities and different tactics. Thank you very much.